The optic nerve is surrounded by the pia-arachnoid jural matter of the nerves leaves the eyeball. The next class is papilledema. Papilledema definition of the papilledema. Papilledema is defined as a passive, bilateral, non-inflammatory swelling of the optic nerve head, secondary to the increased intracranial pressure. It is a passive, bilateral, non-inflammatory swelling. It's non-inflammatory swelling. It is a passive edema of the optic nerve head secondary to the raised intracranial tension, raised intracranial pressure. It is a bilateral and non-inflammatory. Other disc edema. We do to differentiate papilledema to disc edema. Disc edema is swelling of the optic disc may occur without increasing intracranial pressure. When papilledema is when edema, swelling of the optic disc associated with the secondary to the raised intracranial pressure is a papilledema. There is certain disc edema, swelling of the optic disc occurs without increasing intracranial pressure. That is disc edema. It is not a papilledema. Pseudopapilledema. Pseudopapilledema, in some conditions, suppose hyperopia, hypermetropia, small tilted discs, and myelinated nerve fibers, and optic disc drusense may cause elevation of the optic disc without any increase in CSF pressure. This is pseudopapilledema. It is not papilledema. Papilledema is nothing but swelling of the optic nerve head secondary to the raised intracranial pressure is papilledema. Sometimes pseudopapilledema, the conditions of pseudopapilledema, hyperopia, small tilted disc, myelinated nerve fibers, optic disc drusen, may cause an elevation of the optic disc without any increase in CSF pressure is pseudopapilledema. Circulation of the cerebrospinal fluid is secreted from the cerebral space from the lateral ventricles. These are the lateral ventricles which is secreted from the lateral ventricles. It passes into the third ventricle, then aqueduct, then it goes to the fourth ventricle. This is the fourth ventricle. So any obstruction from the either in the lateral ventricles, in the aqueduct, and to the fourth ventricle causes the right intracranial tension. This is a subarachnoid space. So this circulation of the any obstruction in the circulation of the cerebrospinal fluid leads to the raised intracranial tension, which is causing the papilledema. This is the lateral ventricles. This is the third ventricle, and this is aqueduct. Any obstruction in the stenosis of the aqueduct series. This is the fourth ventricle. This is the aqueduct. Then fourth ventricle. This circulation of cerebrospinal fluid. Cerebrospinal CSF pressure. Cerebrospinal fluid pressure. Normal CSF pressure is usually in the range of 100 to 250 millimeters of water. It can be calculated as water to 100 to 250 millimeters. CSF pressure equal to the or greater than 250 millimeters of water taken in the person lying in the lateral recumbent position is considered abnormally elevated. And CSF pressure and more than 250 millimeters of water when person lying in the lateral recumbent position is considered abnormally elevated. Any rise in CSF pressure which leads to the raised intracranial tension leads to the papilledema. The subarachnoid space around the optic nerve is continuous with the subarachnoid space around the brain. The optic nerve is nothing but is a continuation of the white matter, and the optic nerve is surrounded by the pile-arachnoid and dural matter sheaths, meningeal sheaths. So subarachnoid space around the optic nerve is continuous with the subarachnoid space around the brain. So any rise in the intracranial tension can leave effect on the optic nerve due to the continuation of the subarachnoid space around the brain. Flow of the axons for the supply of the nutrients is an active process depending on the energy and enough vascular supply. So axonal strength is depends upon the nutrients supplied by the active process, depend energy enough by the vascular supply. So any ischemia, any causing to the axons of the optic nerve leads to the atrophy and degeneration changes. Pathophysiology, when a intracranial tension raised intracranial tension transmit elevated CSF pressure in the subarachnoid space around the optic nerve. This optic nerve is surrounded by the subarachnoid spaces, sheaths and dural sheaths, and it is also elevated. So this increased the intracranial tension disrupt the orthograde exoplasmic flow of the nerves. So which can lead to this interruption of the exoplasmic outflow leads to the axonal swelling. As the axons are swollen, nerve fibers are swollen, the disc shows edematous and raised and edematous. Mild disc edema is present. As papillary intracranial tension is continuous, this extracellular fluid has to edema accumulated into the nerve fiber layers, and which further leads to the venous engorgement of the veins and venous generally compression. Later leads to the venous compression and the ischemia. Later it leads to the ischemia with papilledema. This raised intracranial tension, subarachnoid space around the optic nerve, which leads to the orthograde, interrupted exoplasmic outflow leads to the axonal swelling of the nerve fibers, and this leads to the mild disc edema. Then accumulation of the fluid accumulation with the nerve fiber layers, then which leads to the compression of the venous compression and ischemia. Later it develops papillary edema of the optic disc. This is the pathophysiology of the papilledema. These are the circulation of the papilledema. Circulation of cerebrospinal fluid, rise of intracranial tension. This is the left ventricle, arachnoid villi, third ventricle's aqueduct, and the fourth ventricle. So, can lead to the raised intracranial tension. It can be due to the aqueductal stenosis, tumors, and blood protein venous obstructions. It can be lead to the raised intracranial tensions leading to the papilledema. Causes of papilledema. Idiopathic, it can be idiopathic. Obstruction of the ventricular systems due to the stenosis, subaqueduct stenosis, or intracranial space occupying lesions. It can be hemorrhage or tumors, intracranial space occupying lesions. It can be hemorrhages or tumors. Impairment of the CSF absorption. It can be due to the meningitis, subarachnoid hemorrhage, and cerebral trauma. Impairment of the CSF absorption due to the meningitis, subarachnoid hemorrhage, and cerebral trauma. Cerebral venous sinus thrombosis causes cerebral venous sinus thrombosis leading to the raised intracranial tension and papilledema. Diffuse cerebral edema, diffuse cerebral due to the burn, head injury. Head injuries can be lead to diffuse cerebral edema due to the papilledema. Severe systemic hypertension, hypersecretion of CSF due to the choroid plexus tumor, and breast and other systemic disorders. These are the causes of the papilledema, which can be idiopathic, obstruction of the ventricular system, intracranial space occupying lesions, including hemorrhage, impairment of the cerebrospinal fluid absorption due to the meningitis and subarachnoid hemorrhage, cerebral venous sinus thrombosis, diffuse cerebral edema due to the blunt injury, head injuries, head trauma lead to the diffuse cerebral edema, severe systemic hypertension, secretion of CSF, and drugs and systemic disorders. These are the causes of the papilledema. Papilledema, sometimes it can be unilateral papilledema. Unilateral papilledema, primary optic atrophy with contralateral papilledema is a Foster-Candie syndrome. It is seen in the Foster-Candie syndrome. Foster-Candie syndrome, here the optic atrophy is present, and the optic nerve is degenerated. Papilledema changes, edematous changes, that is elevated disc, swollen disc, elevated and the blurring of the margins, venous conditions is not seen in the optic atrophy. So this is a papilledema when optic atrophy on one side and papilledema on the other side is a Foster-Candie syndrome, the contralateral papilledema. When there is pre-existing unilateral optic atrophy, this is a unilateral optic atrophy. When congenital acquired arachnoid sheath disorders is a optic asthma arachnoid seen in optic asthma radiolitis. Unilateral optic atrophy in one eye. It cannot be established papilledema, disc edema. So, in the papilledema is established in other eye. This is unilateral papilledema. This may be seen in Foster-Candie syndrome. This is a normal optic disc. You can see the well-defined margins, the pinkish in color. These are the wings and AV ratio 2:3. And the retinal, there is retinal fiber layers, transparent layers, and this is a macula. This is a cup, and the wings are normal. Margins are well defined. You can see the margins. This is a normal optic disc. Now fiber layers, other surrounding retina. Other surrounding retina is normal. No hemorrhages, no exudates. So cup is normal. The ratio is normal. And these veins are normal. Everything is normal. This is a normal optic disc. And the signs of the papilledema. Signs of the papilledema. This is in the papilledema. Disc is elevated. Compared to the retina, surrounding retina to the disc, this is the disc is elevated. Margins are blurred superiorly, inferiorly, nasal margins are blurred. Blurring of the disc margins, not margins are blurred. Disc is hyperemic, the reddish hue is present. Filling of the physiological, this is the physiological cup. Due to the edema changes, physiological cup is filled up. Filling of the physiological cup. This is the edema of the peripapillary nerve fiber layers. This is edema. Edema of the peripapillary nerve fiber layers. And the retinal, as edema is advanced, it leads to the retinal and choroidal folds. Yes, this is early papilledema, where the less for a folds are seen, edema is minimum. So early these signs are elevation of the optic disc, blurring of the disc margins. The disc is elevated to 6 in diameters due to the accumulation of the fluid, passive fluid. Filling of the physiological cup is filled out. Margins superior, inferior, nasal margins are flat. Temporal margins are well defined. This early papilledema. Edema of the peripheral nerve. This slight edema is present. Peripapillary nerve fiber layer and retinal nerve choroidal folds. Vascular signs of hyperemic disc. Disc is hyperemic. Here reddish hue is present. In case in Kestenbaum signs, in case number of the vessels over the disc is present, vessels are tortuous and congestion of the vessels is present. Veins are tortuous, engorgement of veins and congestion of the veins is present. Veins are sometimes here buried. This peripapillary hemorrhages, small peripapillary hemorrhages are present. Exudates is present in the disc and the peripapillary area. Nerve fiber layer infarct. These are present in the nerve fiber layer infarct is present in the as advanced delayed papilledema. So, increase hyperemia of the disc, increase in the custom bond, increase number of the vessels, so the disc is increased. Vascular congestion is present. Peripapillary hemorrhages are present and exudates in the disc and peripapillary area. And now fiber layer infarct is present. These are the vascular signs of the hyperemic of the disc, papilledema. Papilledema, how to diagnose the papilledema? Early papilledema, visual symptoms. And early stage, visual symptoms are absent. Early papilledema, visual symptoms are absent. And disc is hyperemic disc. Disc is hyperemic. And indistinct margins are blurred. Margin, cup is preserved. Early stages, physiological cup is present. As edema advances, this cup is filled up. Absence of spontaneous venous pulsations. Normal venous pulsations are present. When the spontaneous venous pulsation is absent, it indicates papilledema. Visual symptoms in early papilledema, visual symptoms is present. Other than no visual symptoms, visual acuity is normal in the early papilledema. Disc is slightly hyperemic. This is slightly hyperemic. The indistinct margins. In early papilledema, characteristic features is margins are blurred and slight elevation of the disc is present. Cup is normal. Physiological cup is normal. Is not filled up. Absence of spontaneous venous pulsations are present. Venous pulsations is absent in papilledema. It indicates the papilledema. This is a grade 1 papilledema. You can see hyperemic disc. This is the disc is hyperemic. Margins are blurred. The disc is margins are blurred. It is superior, nasal, inferior margins are blurred, except temporal margin is present. Indistinct venous congestion is present. Cup, you can see the cup, and retina now surrounding retina edema is present. Slight edema is present. This is early grade 1 papilledema. Veins are engorged and tortuous. Here the veins are present. Cup is seen. Physiological cup is seen. This is the grade 1 papilledema. Stages of papilledema. Early nerve fiber edema is first seen in superiorly. This is the stages of grade 1 papilledema. There is a margins are blurred, indistinct, superior, inferior margins and nasal margins are blurred. Venous congestion is present. This is hyperemic. Cup is seen, and this is the blurred margins and marked venous congestions. Venous dilatation is present. Cup is filled up. Margins are blurred. Superior, inferior, nasal margins. Later, lateral margins. This is the papilledema. Established papilledema. As intracranial tension is increases, so it is not relieved. Intracranial tension. So as advanced papilledema, the edema is also more in the optic nerve disc. So papilledema is advanced. These margins are more indistinct. You can see the pattern folds, which is a characteristic feature of papilledema. Pattern folds is nothing but folds of the retinal fiber layers, and cup is as advanced, cup is filled up. Disc elevation of the disc. Chronic papilledema more hard. ఒక్కసారి ఇట్రానా సరే advanced established papilledema, venous engorgement and tortuosity. Disc is elevated more than 3 diopters. Venous engorgement and tortuosity is present. And the flame-shaped hemorrhages are present around the disc, hard exudates is present. In established papilledema, disc elevation is more than 3 diopters, venous engorgement and tortuous is present. Hemorrhages are present, flame-shaped hemorrhages are present at the disc and hard exudates is present. This is established papilledema. This is the grade 2 papilledema, established papilledema. The margins are blurred, venous engorgement is present, hemorrhages, small hemorrhages is present, there is hard exudates is present, established papilledema. Chronic papilledema. As edema is increased, there is going on increase in raised intracranial tension, and there is atrophic changes is present in a late papilledema, chronic papilledema. Disc becomes disc elevated, pale in appearance. It becomes paler in color due to the degeneration of the axons. Margins are blurred, margins still blurred in present, and more hard exudates and gliosis. As edema is advances, it can be exudates leads into the more hard exudates and gliosis is present. Hemorrhages and exudates are gradually resolved in chronic papilledema. Markedly swollen disc is present. Markedly swollen disc is markedly swollen. Disc is elevated and becomes paler in color as advanced papilledema and atrophic changes. And gliosis, when gliosis is present and leads to the axonal degeneration, becomes atrophy. Optic nerve becomes atrophy. Then margins are blurred, more hard exudates and gliosis is present. And hemorrhages or exudates gradually resolves and markedly swollen from disc is present. This is advanced papilledema. Chronic papilledema is the stage of chronic papilledema, marked elevation of the disc with no hemorrhages and cotton wool spots is present. In due to raised intracranial hemorrhages, distinct margins are blurred. All superior, inferior, and nasal and temporal margins are blurred. Disc is elevated and venous congestion is present. Veins are tortuous and congestion is present. Cup is filled up. Surrounding retinal edema is present. Grade 4 papilledema, it is a grade 4. See, in the swelling the hemorrhages swollen and becomes paler in color. And these hemorrhages are present over the disc. Venous engorgement is present. Tortuous is, cup is filled and it is more elevated. Disc is more elevated. This is a grade 4 papilledema. And atrophic papilledema, and as advanced, as age advanced, there is edema becomes decreased and become atrophic stage. This is optic now goes the atrophic changes, dirty white appearance of the disc and the relative gliosis from the disc and goes axons become atrophied. At this stage, sudden blindness is present at this stage. Attenuation and the sheathing of the peripapillary part of the vessels. And this is atrophic papilledema. Dirty white appearance of the disc and the reactive gliosis from disc. Attenuation and sheathing of the peripapillary part of the disc. Differential diagnosis of the papilledema. Bilateral disc edema. These are the few causes for the differential diagnosis of papilledema. It is bilateral hypertensive retinopathy, diabetic retinopathy, cavernous sinus thrombosis, cavernous fistula, CC fistula, advanced Graves' disease, acute stages of LHOA, anemia, and hypoxia. These are the differential diagnosis of the papilledema. Bilateral disc edema. This is hypertensive retinopathy. It is a systemic disease. So hypertension retinopathy involves bilaterally. So as a advance hypertension, it leads to the edema of disc. And diabetic retinopathy is similar. Cavernous sinus thrombosis, it leads to the bilateral. CC fistula advanced grape disease, anemia, and hypoxia. These are a few causes for the differential diagnosis of the papilledema. Differential diagnosis of the unilateral disc edema. It is not a papilledema. Other causes: optic neuritis, AION, anterior ischemic optic neuropathy, CRBO, periphlebitis, papillophlebitis, compressor of the optic nerve in the optic disc, the orbit, ocular hypotony, LHON. Optic neuritis, AION, CRBO, papillophlebitis, ocular hypotony, LHON. Differential diagnosis of papilledema. Unilateral disc edema. These are not papilledema because these conditions is not associated with raised intracranial tension. Optic neuritis, AION, CRBO, but disc edema is present. Unilateral disc edema. Other causes: pseudopapilledema, high hypermetropia, congenital disc anomalies, lucence of the optic nerve head, myelinated nerve fibers, Weissenster's papillae. Pseudopapilledema, high hypermetropia, congenital disc anomaly. Other causes: lucent optic nerve head, myelinated nerve fibers. Pseudopapilledema. In pseudopapilledema, a papilledema is present, edema of the disc is present, but it is not associated with raised intracranial tension. Patient with elevated optic nerve is present from birth. Optic nerve head disc edema is present. Visit this, margins are blurred, and optic disc is elevated. No major blood vessels covering a small nerve, and abnormal branching. Vessels are, there is abnormal branching of the vessels. Abnormal tortuosity of the vessels is present. Margins are blurred. Disc is elevated. This is the pseudopapilledema. Pseudopapilledema is not a physiological condition. It is not elevated with raised intracranial tension. Differential diagnosis: true disc edema, pseudopapilledema. These are a few points for differential diagnosis. Disc vasculature is obscured. Disc marginal vasculature is clear. Elevation of the peripapillary nerve fiber layers. True disc edema. Elevation conformed only to the disc. Obscuration of the peripapillary nerve fiber layer. Sharp peripapillary nerve fiber layer. Venous congestion is common. In true disc edema, no venous congestion. Exudates and the cotton wool spots may be present. No exudates, cotton wool spots are seen. Loss of cup is a late feature. Small cup is seen. Normal disc vessels except collaterals. Anomalous disc vessels may be present. Absent venous pulsations seen in papilledema. True disc edema, papilledema. Spontaneous venous pulsation may not be noted. These are a few points for the true disc edema and pseudo papilledema. You can differentiate differential diagnosis from the papillitis, papilledema, and pseudo papilledema. So in the papillitis, visual symptoms. There is loss of vision, profound loss of vision is present in the papillitis. In papilledema, visual loss is minimal. And pseudopapilledema may be asymptomatic or coincidental. It is acute, usually insidious, usually coincidental. Pseudopapilledema. Papillitis, usually associated ocular findings, usually associated. Papillitis is inflammation of the optic nerve. This papilledema is raised due to raised intracranial edema of the disc papilledema. In papilledema, also our findings, oculomotor nerve paralysis, other cranial nerve paralysis, loss of corneal sensation is seen in papilledema. Because this raised intracranial tension, which can be lead to the other cranial nerve palsy, as a sixth cranial nerve palsy, third cranial nerve palsy. So it leads to the associated with papilledema. Then disc elevation in papillitis, mild to moderate, 2 to 3 disc diameters, moderate to marked, and mild to moderate. Disc posterior vitreous changes is seen in papillitis, clear normal in papilledema. Disc morphology, hyperemic, blurred margins, usually no other findings. In addition, measure peripapillary edema, hemorrhages or X-rays are seen in papilledema. Small disc with mild margins is present. Color vision usually impaired in papillitis, usually normal in papilledema, usually normal in pseudopapilledema. Visual fields, classically generalized reduction of sensitivity of the central scotoma, enlargement of the blind spot, and bitemporal hemianopias and may have field defects pattern. Enlargement of the blind spot and bitemporal hemianopia is characteristic visual field defects in papilledema, usually normal in pseudopapilledema. Investigations, MRI is must for papilledema to differentiate PEP, visually evoked potential. MRI is fun. CT scan is must for the differentiate papilledema. How to approach the patient with a patient? A papilledema is an emergency. Due to the if you not diagnose a papilledema, the patient goes to the blind. If you detect early and if the intracranial tension is decreases, you can save the eye. Otherwise, person can go to the atrophy when papilledema leads to the atrophy, optic atrophy, you become blind. It is also bilateral condition. So it is an emergency papilledema. Once you diagnose, it is an emergency condition. We should immediately decrease the intracranial tension, or you can give the treatment for the raised intracranial tension. And you refer to the neurophysician and neurosurgeon. So it is an emergency. Appropriate history, visual complaints associated. It can be see the associated ocular features and proptosis, visual loss, extraocular muscle dysfunctions. Visual field examination in papilledema, you should see the visual field examination. Must. In visual field examination, if there is enlargement of the blind spot and scotomas and field defects, you can suspect papilledema. It is an emergency condition. So immediately once the papilledema is diagnosed, you should decrease the intracranial tension and relieve the pressure on the optic nerve. Otherwise, it goes to the atrophic changes and person become blind. Because it is a once optic nerve is degenerated, atrophy, the vision cannot be restored. It can be there is no regeneration for the optic nerve. Once it is goes to the degeneration becomes atrophic stage. The visual field examination, it's the optic neuritis, anterior ischemic optic neuropathies, and these are the differential chiasmal tumors. It can be differentiated by the visual field examination. Role of imaging and computerized tomography, CT scan and MRI is the must. Once you suspect a papilledema, so you should locate the papilledema is a sign. It is not a disease, it is a sign. So you should suspect where is the cause of the lesion, either intracranial tumors or meningitis or CCF fistula, cavernous sinus thrombosis or CCF fistula and other causes, or stenosis. These are the you should suspect. You should visualize the causes of the papilledema. So MRI is must. MRI, CT and MRI is must if you once you diagnose the papilledema. CSF analysis. You can see the for analysis, we differentiate whether meningitis or encephalitis. Or you can diagnose when it comes to diagnose CNS lymphoma and CNS tumors. CSF analysis is must. Or the idiopathic intracranial hypertension. CSF analysis must differentiate whether it is due to the papilledema due to the meningitis, or encephalitis, or lymphoma, CNS lymphomas as CNS tumors. OCT is potential tool to qualify changes in the degree of papilledema to monitor accuracy. OCT is must to know the stages of the papilledema. Changes in the stages of whether papilledema is advanced or can be atrophied. OCT is must to monitor the accuracy of the treatment. Diagnostic clues. More changes in the disc. If the changes in this, think of neurological problem. Less when the changes of the disc is less, such as elevation of the disc is less and the retina surrounding edema is less, then think of the intraocular problems. If disc changes is more, disc is markedly elevated, surrounding changes in the retina, this is for the neurological. That is, you can diagnose the papilledema. Detailed history taking, optic disc evaluation is must. For any case of papilledema, evaluation every day you should evaluate the disc, changes in the disc and the raised disc. Then ancillary visual testings and visual field analysis is must to diagnose whether the papilledema, to differentiate whether it is a papilledema or papillitis or optic neuritis. And last is neuroimaging, CT, MRI is must for the etiological diagnosis in most of the cases. You should know the lesion, where the lesion is present. Etiological diagnosis by the or tumors or meningitis or hemorrhages, intracranial lesions. Know the etiological diagnosis, neuroimaging, MRI or CT scan is must. Papilledema is nothing, it is a sign, and detailed evaluation should be done to reach the final diagnosis. It is only sign, papilledema. The patient with disc edema is optic disc edema. Appropriate examination whether it is a true disc edema or pseudo disc edema. In the true disc edema, unilateral or bilateral. True pseudo disc edema, it can be drusen and hypermetropia. Appropriate examination is by the fundus examination, whether it is a true disc edema or pseudo disc edema. It can be unilateral or bilateral. Visual loss. Visual loss is present. Yes, is present. Evaluate the optic neuropathy. It can be papillitis, ischemic optic neuropathy. With papilledema, visual loss is not present. Very, very late stage under the papilledema only visual loss is present. Then slight blurring of the vision is present only in the early stages. If there is no visual loss, approach with systemic and ocular findings and visual. If there is an apoptosis, systemically ill fever and prostration, transient obstruction of the brain. If the proptosis, you go for a CSF analysis and neuroimaging. Systemically ill, orbital and brain imaging. There is a transient obscuration vision. This characteristic feature of the papilledema, go for the MRI, brain. And if MRI, you suspect any lesions, go for immediately refer to the neurosurgeon. MRI brain is positive, CSF opening pressure is normal, very increased, normal cytology, idiopathic intracranial diagnosis as idiopathic intracranial tension is normal. It consider details uremia, metabolic diseases and spinal cord lesions. Treatment. Treatment, the cause of the raised intracranial tension. Range from the weight loss to extensive neurosurgery. The treatment should be give the cause. Whether the papilledema is due to the meningitis, treat the meningitis. The papilledema due to the tumors, you treat to remove the tumors. Or if papilledema can be the CSF, cavernous sinus thrombosis, CC fistulas, or arachidonitis, stenosis. We treat the causes first. Then they decreases the papilledema. The class is over. Thank you.